topic of lecture is dental caries. Lecture outlines dental caries, definition, modern concept of the etiology and pathogenesis of disease, classification of dental caries, clinical manifestations, diagnostics and differential diagnostics of caries, the use of physical methods for caries diagnostics. Caries is the most common cause of the toothache and tooth loss in adults and children. Despite advances in restorative materials and the implementation of various preventive approaches, more than 90% of adults have experienced dental caries before 30 years of age. Caries is a dynamic process. It is characterized by episodic demineralization and remineralization occurring over time. If destruction predominates, disintegration of the mineral component will occur, leading to cavitation. And this diagram shows the modern concept of caries etiology. And it compounds of such parts. First of all, it is tooth and susceptible surfaces of it, proximal, cervical, occlusal, teeth, and of course, microorganisms, especially the most cariogenic, it is Streptococcus mutans. Of course, cariogenic food that is full with fermentable carbohydrates, high, easy digestible carbohydrates. So such type of food, easy to stick, easy to glue to the tooth surface, plus microorganisms, and of course, do not forget about time, because time it is essential criteria for all these parts to cooperate. And if there is a sufficient period of time, there will be development of caries. And in this process, we cannot forget about saliva. As saliva, it is that environment in which all organs of oral cavity and teeth in particular are moistened, are covered by it all the time. So such criteria of saliva as flow rate, its composition, and buffering capacity is of great importance either in caries progression or caries prevention. Dental caries is a complex pathological process that occurs after tooth eruption, with a subsequent demineralization and softening of dental hard tissues, leading to cavitation, in a consequence of local and general factors. So this is definition that we use to describe caries process. Factors of dental caries development. They are grouped in such three big categories: general factors, local factors, and violation of resistance of dental tissues. So general factors are such: insufficient nutrition and bad quality of potable water, general diseases and disorders of the human organism, and extreme impacts, ionizing radiation, hypothermia, or overheating. Local factors are such: dental plaque, microorganisms that persist into dental plaque, violation of properties and composition of oral fluid, remnants, and dietary carbohydrates. Violation of resistance of dental tissues. To this group of risk factors belong such: inadequate structure, hypoplasia, amelogenesis imperfecta, etc., violation of the chemical composition of hard tooth tissues, unfavorable genetic code. In this diagram, similar idea that was on the previous slide, but it is described in pictures for better memorizing and easy understanding um, the general factors that influence the development of tooth decay. So, nutrition plays a great role in caries either prevention or progression. So, cariogenic nutrition, it is candies, sweets, chocolate, so easy, very sticky food. But food such as vegetables, it is that food that is healthy, that will prevent accumulation of tooth decay on the teeth, of plaque on the teeth, excuse me. The next, it is drinking water. Potable water is of great importance because water can either mineralize tooth structure or act opposite. Somatic diseases, without any doubt, state of the human organism, state of the inner organs influence um, influence the health of the oral cavity, influence the state of the saliva. And saliva is that liquid that can act in mineralizing or demineralizing of tooth tissues. So somatic diseases as well plays a role in caries progression. And extreme impacts that influence the human body, overheating or lower temperature and ionizing radiation, without any doubt, it is one more impact that influence not only the teeth and tooth decay, but it influences the whole human organism, and as a result, oral cavity is a part of human organism, so there is a not direct influence, but through internal diseases, somatic diseases, this ionizing radiation will do some impact on the teeth as well, and tooth decay in particular. Local factors such as plaque, and do not forget about host surface, cervical areas, proximal areas. It is that places where plaque can accumulate, and that places where this plaque can stay for a long time, not being disturbed by a toothbrush, because proximal surfaces, it's very hard to brush by a toothbrush only. And extra armamentarium is essential to use for better cleaning. The next, it is carbohydrates and food that will easy stick to the teeth. Flow rate of saliva and its composition, and of course pH level. As I have said before, saliva, it is that environment where teeth are best mouthwashed all the time, and quality of saliva and its rate has a direct influence on tooth decay progression. Microorganisms that live in the tooth plaque as well, Streptococcus mutans, it is that the most aggressive one, who is outlined in almost all species that were taken from the caries cavities. Vitamin D, it is that factor that will improve the health in general, will together with calcium, vitamin D will improve the hardness of enamel. So it's important to keep in mind that this vitamin will, together with calcium, will prevent tooth decay. And time. Time, it is that factor that under which all these factors co-interact together, and due to sufficient period of time of the co-interaction of different factors, there will be possible tooth decay progression. Special attention should be paid to bacteria, to microorganisms that are commonly found in oral cavity. Actually, in oral cavity, there is more than 700 species of microorganisms. Among them are defined such as Staphylococcus group, Streptococcus group, Enterococcus, Neisseria, Veillonella, Enterobacteria, Proteus, Candida albicans, Actinomyces, Porphyromonas gingivalis, Bifidobacterium species. But the most aggressive, once again, I'm focusing on it and stressing your attention that the most aggressive, the most cariogenic microorganism among these microorganisms is Streptococcus mutans. He is responsible for tooth decay. Local cariogenic factors and the role of microorganisms, especially Streptococcus mutans, in caries formation. These microorganisms play very great role to facilitate caries formation. This one, here it is, his microbiological photo. So it can readily ferment dietary carbohydrates to produce acid. It can synthesize dextran from sucrose. The later one helps in adhering the bacteria as well as acid on the tooth surface. It has ability to adhere and grow even on hard and smooth surfaces of the teeth. This slide shows you importance of saliva in caries etiology. And to understand the role of saliva in caries progression, necessary to refresh the functions of saliva. And these are the most important that act in caries either progression or preventing. So the first one is remineralization capacity of saliva. This is maintained due to calcium and phosphate ions. If saliva is rich with calcium and phosphate ions, there will be prevention of tooth decay. If opposite, will be progression and development of tooth decay. Cleansing function. It is maintained due to appropriate amount of flow rate of saliva. Daily production, normal daily production, ranges from 500 milliliters to 2 liters daily production. Everything what is less or more, it is some kind of disorder, and this one will of course stimulate tooth decay. The third one function that act in caries either progression or prevention is buffering capacity. So this one is maintained due to bicarbonate and phosphate buffers in oral fluid. By the way, oral fluid and saliva, actually saliva, it is pure secretion from salivary glands, but when we talk about that what we see in oral cavity, it is oral fluid, because it is not only pure secretion but also remnants of food, remnants of particles of some microorganisms, leukocytes, and so on. So that is oral fluid. When we say saliva, we mean oral fluid. By the way, buffering capacity can regulate pH in oral cavity, changing it from acidic to alkaline rate. And a few more functions that saliva have. It is protective due to lysozyme and immunoglobulins A, histatins and lactoferrin. By the way, histatins as well kills microorganisms, and lysozyme act in stimulating local immune system of oral mucosa. Digestive and taste function is maintained due to alpha amylase that is present in oral cavity, and this one act in digesting starches. Protease as well, it is that components that act in digestive in oral cavity. So the first break of starches actually due to alpha amylase is done in oral cavity. And zinc is responsible for taste. Mucins that are present in oral cavity is responsible for bolus formation. And of course they coat oral cavity because they are present in saliva. Saliva coat oral cavity, and thus there is better articulation, easy communication. It is comfortable to talk, to swallow food. So mucins, these components present in oral cavity act in bolus formation. And of course, lubrication, another function of saliva, it is lubrication. It helps in articulation. So this function is maintained due to proline-rich glycoprotein and of course mucins. These two are responsible both for bolus formation and easy swallowing and of course articulation. Role of bacterial plaque in tooth decay. So the plaque is a thin, transparent film produced on tooth surface consisting predominantly of microorganisms suspended in salivary mucins and extracellular bacterial polysaccharides. Also presence of desquamated epithelial cells, leukocytes, and food debris, etc. The dental plaque helps initiation of caries by following ways. It harbors the cariogenic bacteria on the tooth surface. It holds the acids on the tooth surface for a long duration. It protects the acids produced by the bacteria from getting neutralized. So these are options by which dental plaque helps initiation of caries. And a few more statements that is necessary to say, that drop in local pH causes demineralization of tooth surface. Below the critical pH 5.5, the tooth minerals act as buffers and lose calcium and phosphate ions into the plaque. So this is the critical pH under which the minerals is lost and there is initiation of tooth decay. Pathogenesis of dental caries can be described following such steps. It was described by Featherstone in 1983. So the first one, it is acidogenic, acid-producing oral plaque bacteria ferment carbohydrates that are taken into the mouth, thereby producing organic acids including lactic, formic, acetic, and propionic. Second, these acids diffuse into the enamel, dentine or cementum, partially dissolving the mineral crystals that is composed of carbonated hydroxyapatite. As they travel, mineral, calcium and phosphate diffuses out of the tooth, leading eventually to cavitation if the process continues. Fourth, demineralization can be reversed by calcium and phosphate together with fluoride diffusing into the tooth and depositing a new veneer on the crystal remnants in the non-cavitated lesion. This is remineralization. The new mineral crystal surface is much more resistant to acid as compared with the original carbonated hydroxyapatite mineral. 6. The process of demineralization and remineralization generally occurs numerous times daily, leading either to cavitation, to repair and reversal, or to maintenance of the status quo. The same, what was given in the text format, the same here is described in this diagram for easier and better understanding of the process of the pathogenesis of tooth decay. So here we have two arrows, that is time. Of course, it is important option, time, and due to time and these activities that constantly occur in oral cavity, we can talk about caries progress. So at the initial stage, there is adhesion of microorganism, colonization of tooth surface, plaque, localization of microorganisms in the plaque. At this stage, we can talk about de and remineralization because there is either improvement of oral hygiene, toothbrushing, taking off some components that remove tooth plaque. And so at this stage, we talk about de and remineralization, this process that occur in the oral cavity numerous times a day. If a process of demineralization proceed, there is formation of white spot lesion. So demineralized enamel is visible. So at this stage, white spot lesion, it can be diagnosed. It can be diagnosed, and at this stage, it can be reversed by using of fluoride containing liquids, by improving oral hygiene, etc. If this was not done, was not diagnosed, tooth decay progress, white spot lesion progress to enamel lesion. So at this stage, we talk about cavity formation. And actually, if there is enamel lesion, there is no process, there is no way to be reversed. That's why we talk about restoration at this stage. And if there is no restoration at this stage, there is a continuation of process, and then we have dentine lesion, and the final step, the final progress of tooth decay, it is pulpal lesion. So caries, tooth decay can be progressed from white spot lesion till pulpal lesion. We have finished with etiology and pathogenesis of tooth decay, and now we are on the question that deals with classification of tooth decay. So, classification varies, but in this lecture, I suggest that classification that we use in our study system of Ukraine. So, the first, it is clinical classification. According to clinical classification, caries is classified on initial, white spot lesion, superficial, medium, and deep. Here you have the Latin names of these diseases. This photo shows you medium caries lesion. This one shows you initial lesion. It means white spot lesion. And here we have superficial caries, caries of enamel, chronic process. The next, it is anatomical classification. According to this, the caries can be classified on caries of enamel, caries of dentine, and caries of cement. Here we have caries of enamel, pit and fissure caries, caries of dentine, and caries of cement of the root. Enamel caries. It is called Incipient lesion, it is synonyms actually. Enamel caries, incipient lesion, it is the same meaning. Incipient lesion is also called the early caries lesion. It manifests as a wide, opaque region which is best demarcated when the area is dried. And actually, here you have. This is white spot lesion, area of demineralization of enamel. In this photo, cavity even is seen, but this is white spot, this is white spot, white spot, white spot. And due to accumulation of plaque, not only tooth enamel is suffered by, but also gums. Due to accumulation of plaque, there is gingival inflammation. Microorganisms and their byproducts destroy capillaries of microvasculature of gums, and thus there is inflammation, bleeding, and pain. Dentinal caries. On its way to progression, caries lesion involves dentine, and over a period of time when the cariogenic challenge becomes more and more strong, the lesion establishes in dentine. At the same time, outer layer of enamel might break down owing to progression of caries and leads to cavitation. So this is medium depth cavities. Soft, wet dentine. And this is chronic medium caries. This is brown, dark, dentine, hard when probing. Root caries can occur in the areas of abrasion, erosion, and abfraction, or as a primary root caries and recurrent decay. The term primary, as it is used with root caries, refers to new dental caries occurring in the absence of a restoration. Secondary, recurrent root caries refers to caries occurring adjacent to an existing restoration. The third group of classification of tooth decay is based on localization. According to it, caries is classified on fissures and pits, proximal surfaces or interproximal surfaces if it goes about anterior group of teeth, and proximal surfaces, and cervical surface, cervical part of the tooth. Classification of caries that is based on a severity and activity of disease. According to this, we have acute, chronic, rampant, secondary, arrested or stopped, and residual. That is acute process, this is chronic process. And here we can see as well arrested or stopped caries. Okay, I will focus your attention at chronic and acute process. What is the difference between them? So if it goes about acute process, the entrance to the caries cavity is always narrow. And here we have undermining edges of enamel. Undermining means that they are not supported by dentine. This cavity is wide enough. Consistency of dentine. It is wet, soft, yellowish, and yellowish or whitish. If it is chronic cause, the entrance to the caries cavity is wide. There is no undermining edges of enamel, so entrance is wide. Consistency of dentine, it is hard, brown on color or dark brown, and as well cavity is wide here. Both entrance and cavity itself is wide. So it is chronic process. That is a comparative under comparative differences of acute and chronic process of tooth decay. And now about rampant caries. So rampant caries occurs as a sudden, rapid, and almost uncontrollable destruction of teeth, involving surfaces of teeth that are ordinarily relatively caries-free. Proximal and cervical surfaces of anterior teeth, including the mandibular incisors, get affected. Actually, these photos shows rampant caries. Numerous teeth, more than one surface is affected. That is rampant caries. It is typical for children in majority of cases, but as well, rampant caries is typical for adults. If it goes about dental therapy department and adult patients, rampant caries will develop in those who have radiation therapy or those who have diseases of salivary glands or those who have some chemotherapy due to some tumors or radiation therapy due to tumors. So actually this deals with rampant caries deals with impaired function of salivary glands, as saliva cannot normally wash teeth, provide mineralization of them, cannot saturate them by calcium and phosphate ions, and low flow rate prevent from washing of the teeth from debris, from food, and actually that is the reason of rampant caries in adult patients. Once again, I will repeat, it is radiation therapy to some tumors that patient could have, problems with diseases, disorders, different types of disorders of salivary glands, including Sjogren's syndrome, etc. Primary caries. Primary caries is used to differentiate lesions which develop on the healthy enamel surface or on unrestored surfaces from those that develop adjacent to a filling. That is a primary caries. Caries that develops for the first time, was diagnosed for the first time. Secondary caries. This type of caries may result from poor cavity preparation, ditching around an amalgam restoration, a defective restoration, or a combination of these factors. So, in a simple words, secondary caries, it is that develops around existed restorations. Residual caries. It is demineralized tissue that has been left behind before filling is placed. Incomplete removal of caries dentine. So in this case, we talk about residual caries. Accidental residual caries. So such intentional, unintentional mistake, maybe, that can be done, and as a result of it, there is a residual caries. There is a clinical evidence that incipient and even more advanced caries lesions may become arrested if there is a significant shift in oral environmental conditions from those that predispose to caries to that tend to slow the caries process. This is arrested caries. And classification of tooth decay based on the intensity of lesion. It can be compensated, subcompensated, decompensated. Classification of tooth decay based on the presence of complications can be simple, complicated. And final classification, it is Black's classification. According to Black, there are 5 classes of tooth cavities, of caries cavities. The first class, caries cavities, is located on the occlusal surfaces, fissures, pits, Class second, it is caries lesions that occur on proximal surfaces of posterior group of teeth. Class third, caries lesions that develop on proximal surfaces of anterior group of teeth. Class fourth, caries cavities that develop on the proximal surfaces of anterior group of teeth involving angle of the tooth crown or cutting edge. And class fifth, it is caries cavities that is localized on the cervical area of all group of teeth. Clinical manifestations of dental caries. Everything starts from white spot lesion. So white spot lesions. Here we have almost on all teeth this white unpleasant look of the teeth. That is white spot lesions. And here we have cavities that develop as a result of white spot lesions. Due to sufficient period of time, they were not treated. So by red arrows, here it is outlined white spot lesion cavity due to as a result of white spot lesion. So clinical manifestation of white spot lesion or initial caries, it is synonyms. So complaints of the patient. Any complaints on the pain are absent. Aesthetic defect only, especially if the lesion is on the cervical part of front group of teeth. Objective examination. White, chalk-like spots, dull, opaque. If it is acute process, brown, pigmented spots if it is chronic process. Spots are localized as usual in fissures, pits, proximal surfaces, and in the cervical part of teeth. During probing, the surface of the spot is hard and smooth. Spot is stained with metal and blue solution to percentage. Treatment that can be suggested for such disease. Local treatment and general treatment. Local treatment, it is oral hygiene plus remineralization therapy. General treatment means that the patient should be prescribed with calcium and phosphorus in tablets. A low carbohydrates diet should be recommended to the patient, and of course, toothpaste with fluoride. Comparative diagnosis of white spot lesions. White spot lesions encompass three diseases: initial caries, fluorosis, and hypoplasia. That's why we need to differentiate these three diseases between themselves. First of all, we need to memorize and refresh in our minds the definition of tooth decay. Caries, it is that disease that develops after eruption. And in etiology of this disease, we have local reasons such as plaque, such as bad properties of saliva, microorganisms that persist in oral cavity, and general factors such as somatic diseases. So if such options, such criteria, such symptoms can be find out from anamnesis when there is a communication questionnaire of the patient, we need to think about caries. But hypoplasia and fluorosis, it is such disorders that is called non-carious lesions. They are white spot, but they are non-carious origin. The reason for them is different. But they have similar clinical manifestation, white spot. First of all, we need to understand and always keep in mind that caries has such reasons as I have said, local and general, and always develops after eruption. We can clearly find out it from the patient's complaints and from the patient's anamnesis. Together to this, there is a special typical localization of non-carious lesions and tooth decay. Non-carious lesions is localized on areas that are not specific for caries. It is cutting edges, equator of the tooth, cusps of the teeth, and caries has its typical localization. It is cervical areas, proximal areas, and occlusal surfaces, pits, and fissures. So these are criteria that should be taken into account when there is a differentiation, comparative diagnosis of different white spots, caries, hypoplasia, and fluorosis. Moreover, if it goes about fluorosis, we can figure out from patient's anamnesis that he or she lives in a region that has bad property, that had water with bad properties, great amount of fluoride or some other reasons that we can figure out during communication with the patient when there is anamnesis, history taking stage. That's why to set a correct diagnosis, it is necessary to provide very thorough, very detailed questionnaire to outline all possible points, all possible reasons from anamnesis of the patient. So questionnaire is very important stage during examination of the patient. It can aid in setting correct diagnosis. Superficial dental caries. It is caries of enamel. Here we have caries in the pit, caries in the fissures. It is superficial dental caries or caries of enamel. Superficial dental caries and its clinical manifestation. First of all, complaints. Short-term pain, mainly due to sweet, sour irritants. It disappears after irritant is removed. By the way, this criteria of the caries is of critical importance to be memorized. It is type of pain that immediately disappears when irritant is removed. Objective examination. Defect is localized in the borders of enamel. It can be round or oval shape, or it could have irregular edges of caries cavity. Color of defect does not differ from health enamel. During probing, the walls of caries cavity is rough, not painful. Localization. Localization of cavities is typical for all caries. It is fissures, pits, proximal surfaces, occlusal surfaces, cervical parts of the teeth crown. Differential diagnosis is done with such non-carious lesions as acid necrosis of tooth hard tissues, hypoplasia, grooved and pitted form, erosion, medium dental caries. On these pictures, it is shown medium depth cavities, initial view and after cavity preparation. So medium dental caries has such clinical manifestation. Complaints of the patient. Short-term pain due to chemical and temperature irritants. Pay attention. Here we have chemical, sweet, sour, plus temperature stimulation. Pain disappears after irritants is removed. Objective examination. Defect is localized in the mantle dentine. Enamel dentine junction is ruined. During probing, the walls of caries cavity are painful. Bottom of the caries cavity is not painful. Caries cavity is fulfilled with a softened dentine. Localization of cavities. Fissures, pits, proximal surfaces, occlusal surfaces, cervical parts of teeth crown. Differential diagnosis of medium caries is done with such diseases as non-carious diseases, acid necrosis of tooth hard tissues, wedge-shaped defects, deep dental caries. And now clinical manifestation of deep dental caries. Actually, this is the deep cavity. Cavity that is close to the pulp chamber. Cavity is localized in circumpulpal dentine. If it goes about medium depth cavity, as you remember, I have said cavity is localized in mantle dentine. And here, cavity is localized in circumpulpal dentine, close to the pulp. And this is the X-ray of deep cavity. As X-ray, it is very useful extra method of examination of patients. Clinical manifestation of deep dental caries. Complaints of the patient. Short-term pain due to all irritants, chemical, temperature, and mechanical. Pay attention. 3 groups of irritants cause pain to such patients. Pain disappears after irritants removal. It is typical for every caries. Objective examination. A deep caries cavity that spreads to the circumpulpal dentine. Probing of walls and floor of the caries cavity are painful. Pay attention. Probing of walls and floor of the caries cavity is painful. In medium depth cavities, only walls were painful, but if it goes about deep tooth decay, we have extra symptom. It is a pain during probing of floor of the caries cavity. Caries cavity is full filled with softened dentine and remnants of food. Localization of cavities. We have fissures, pits, proximal surfaces, occlusal surfaces, cervical parts of the teeth. The same localization as for every tooth decay. Differential diagnosis is done with pulp hyperemia, as it is the next step in progression of disease. So pulp hyperemia, acute serous localized pulpitis, and chronic fibrous pulpitis. So we differentiate deep dental caries with inflammation of dental pulp. So we have finished with clinical manifestations of different types of tooth decay. So this slide gives you information about histopathology of enamel caries. So the white spot lesions, chalky appearance, is an optical phenomenon caused by mineral loss in the subsurface and surface layers of enamel. Here we have internal loss of minerals, external surface. It is histopathology of enamel caries. Optical phenomenon that is caused by mineral loss in the subsurface and surface layers of enamel. White spot lesions. Subsurface enamel porosity from caries demineralization, manifesting as a milky white opacity of the enamel. This is histopathology of enamel caries. Histopathology of dentine caries. Dentine contains much less mineral and possesses microscopic tubules. that provide the pathway for the entry of acids and egress of mineral. Dentine tubules, and here we have the structure, inner structure of the tooth and structure of dentine, with dentine tubules and odontoblast processes that come from the periphery of the pulp tissue and enter the dentine tubule and even spreads their processes into enamel dentine junction. So odontoblast processes and dentine tubules, numerous dentine tubules. Histopathology of dentine caries. So the dentino-enamel junction has a less resistance to caries attack. Hence, allows for rapid lateral spreading once caries has penetrated the enamel. Because of these characteristics, dentinal caries is V-shaped. Pay attention. V-shaped, like a Latin letter V. Or cone-shaped in cross-section with a wide base at the dentine enamel junction. And the apex directed pulpally. Defense reactions of pulp-dentine complex. Once bacterial invasion of dentine is near to the pulp, toxins and few bacteria enter the pulp, resulting in inflammation of the pulpal tissue. And this photo clearly describes how how this reaction of pain happens. So we have stimulus, thermal, mechanical, chemical, evaporative. We have dentine tubule, we have odontoblast process, we have nerve ending. So if there is a stimulus, exposed dentine, we have open tubules, we have change in rate of dentine fluid flow, we have generation of action potentials in intradental nerves, and finally action potentials pass to brain to cause pain. So that is the pain syndrome. How develops the pain syndrome? In the if the dentine enamel junction is exposed, enamel dentine junction is exposed in starting from medium tooth decay. We have finished with these big questions: classification, etiology, clinical manifestation, and now we move to diagnostic methods for dental caries. Diagnostic methods for dental caries can be grouped in such clinical methods, visual methods, radiography, transillumination as a separate method, and electronic caries meters. Caries occurs on the occlusal, proximal, and buccal lingual surfaces of teeth. On smooth surfaces, the lesions normally develop close to the gingival margin and are often covered in plaque. Those developing in fissures and proximal surfaces are more difficult to detect, and diagnosis usually involves indirect methods. On the buccal and lingual surfaces, the optimal assessment is the visual appearance of the surface. A white spot lesion can be seen when enamel has been cleaned and dried. On those surfaces hidden from direct visual examination, radiographic examination is the most commonly used diagnostic technique. Visual method: white demineralization and a break in the enamel surface show that dentine is involved. Probably the most difficult lesion to assess is recurrent. Caries occurring around existing restorations. Marginal gap and ditches are common around most amalgam restorations. Marginal gaps are sticky to probing and are wider than the width of periodontal probe would generally mean that caries is present and there is a need for operative management. However, pure ditching, which is a breakdown of the amalgam at the tooth surface, does not require restoration. Shadowing a blue-brown discoloration within the tooth and surrounding the restoration can indicate an active lesion. Radiography. Bite-wing radiographs are relatively reliable for detecting proximal lesions, but less so for occlusal lesions. The advancing lesion is therefore relatively underdiagnosed by radiographs. A bite-wing radiograph needs to be taken correctly to have the most diagnostic yield. Approximately, caries will occur below the contact areas and above the alveolar bone. The extent of the lesion spread is more difficult to visualize as the bulk of the enamel and dentine partly obscures the X-rays. X-ray diagnosis. So this X-ray pictures shows the caries cavities that can be find out. Here we have translucency in the tooth enamel. Here we have translucency. And here it is occlusal cavity is shown on X-ray. But as it was said before, occlusal caries can be not correctly diagnosed with X-ray. X-ray is very efficient for hiding caries in proximal surfaces. Transillumination technique. This is a rarely used technique to assess caries on molars and premolars, but more commonly used on anterior teeth. Direct light reflected by dental mirrors onto the teeth can highlight darkened shadows present between the proximal surfaces of upper anterior teeth. Here we have this darkened area on the photos. Electronic caries meters. Recent research has suggested that changes to the electrical impedance of enamel can indicate an active lesion. This technique has the potential to overdiagnose caries by giving false positive results, and so has not resulted in widespread usage. Basically, this one device can show if tooth is vital, if it reacts to current stimulation, or do not react. So that is the most good use of this device, just to find out if the tooth is vital. If vital, it will react to current stimulation. Diagnodent. It is a laser-based technique for caries diagnosis. The light reflectivity from a caries and non-caries surface is different. Like the electronic caries meters, these instruments can overdiagnose caries and potentially confuse stained surfaces with caries ones. Some restorative materials have shown similar fluorescent values to those of caries dentine, and its application for the detection of secondary caries seems questionable. But still, this technique, diagnodent, can be used in such cases if there is a question. Should we prepare or not prepare this spot, this lesion? Is it caries or is it spot? So in these cases, diagnodent will be effective in the questionable cases. In small cavities, of course. Those that are not visible by naked eye or cannot be diagnosed by mirror and probe. And final key points about dental caries. First of all, caries process is spread over time. The initial lesion can be arrested and reversed. All ages are susceptible to caries, and all populations are susceptible to caries. Caries is the major cause of tooth loss in all age groups. And finally, caries is a microbial disease. To sum it up, this lecture, it is worth to mention such proverb that can be used as a rule, or it can be used as a recommendation to every person. An apple a day keeps a doctor away. And actually, this has sense. References and suggested further reading. Art and Science of Operative Dentistry, Studerwarts. Essentials of Dental Caries, Edwina Keith. Dental Caries, the Disease and its Clinical Management, with editors Edwina Keith. And of course, this book, that is Ukrainian one, this trilogy, that was edited under the edition of Professor Danilevsky, Dental Therapy. So actually, these are that books that can be suggested for further reading and as references to this lecture. So thank you for attention and wish you a good day.